Thank you, Dr. Namrata, for giving me invitation to speak on this talk on viral keratitis, clinical presentation and management. After having finished bacterial keratitis and fungal keratitis, we come to this particular disease. This has got a different kind of presentation in a sense that the HSV-I infection, when we get it in the first time, it may not necessarily get, do we have a pointer? Pointer. It may not necessarily lead on to infection. And the biggest bugbear of HSV infection is the latency. And because it leads to latent HSV infection, there is always a possibility of recurrent HSV infections. So that is the way that the disease differs from other microbial or bacterial keratitis, where when we give a particular antibacterial or antifungal, the disease, you get rid of the disease, but not in case of viral keratitis. Primary HSV infection is when we get the first infection in a non-immune host, which may be in the form of blepharitis, conjunctivitis, or a dendritic keratitis. Recurrent ocular HSV infection, that is infection in a previously sensitized host, which may be in the form of a blepharoconjunctivitis, dendritic keratitis, and epithelial keratitis, stromal keratitis, combined forms, endothelitis, limbitis, and iridocyclitis. It's very important to differentiate that which layer of the cornea is affected in case of a viral keratitis, because treatment changes accordingly. The typical epithelial keratitis, which we are all used to seeing, is in the form of a dendritic keratitis, where we get branching linear ulcers and they are fluorescent stain positive, and there is also associated loss of sensations along with that. This is how a typical herpetic keratitis will present. A dendritic keratitis will present in this manner. Patient may just give you acute history of a day or two with severe photophobia and pain, but on fluorescent stain you may be able to see a very nice dendrite. Same, when we diagnose this, you put the patient on topical ACYCLOVIR, and this is what the disease happens after 3 days. Important thing to differentiate is from adenokeratitis. Very often this is confused and taken as the same form as herpetic keratitis, but this is a completely different entity where you get multiple subepithelial infiltrates in post-viral conjunctivitis. The other forms of epithelial keratitis besides dendritic keratitis may be in the form of a geographical or amoeboid ulcer, where we get broad areas of epithelial ulceration, or it may be a marginal keratitis or an indolent epithelial ulcer. This is how a typical amoeboid ulcer looks like when we get a central large defect with, it's like a hydra kind of a presentation. The stromal viral keratitis typically is a condition where we get its antigen-antibody immune reaction is there, while in case of epithelial keratitis, the virus is actually growing in the epithelium. This stromal viral keratitis may assume different forms, the commonest being a disciform keratitis or a deep focal keratitis. Necrotizing keratitis, though not rare, but is commonly seen still, and interstitial keratitis. But the commonest form of viral keratitis which we encounter in our setup is a combined form of superficial keratitis combined with stromal keratitis. The unusual presentations of stromal keratitis is in the form of a diffuse stromal edema. There may be a pigment dusting on the endothelium, and markedly, the hallmark of this lesion is a markedly raised IOP. A typical disciform keratitis comes as a central round corneal stromal lesion, corneal edema, and it, at times residents diagnose it as a corneal opacity, and it's a white eye along with that. A diffuse stromal keratitis, when the deeper layers of the corneal stroma are diffusely affected and it is not associated with any epithelial lesion. These are the pictures of our patients where they get recurrent keratitis, in a sense that when you get this area is healed, this is healed, but if you really look at this slit, you can see a fusiform thing over there. So this is a recurrent keratitis in the form of a stromal keratitis. This is another patient where we get a localized focal edema, or focal edema may come in this manner. So therefore, I'm again and again talking about the recurrent keratitis, which I'm more worried about. This is how another patient who was just one-eyed patient who used to complain of off and on fallen vision, and he would get recurrence of the same lesion, and this is what I've taken a high mag to show that there occurs a focal edema in these cases. At times they may present just in this form of a local endothelitis, where there occurs small KPs and local fusiform edema. The recurrent keratouveitis, you may have a stain positive. The other form of this is a trophic keratitis, where you have a damaged basement membrane, and earlier it used to be called as a metaherpetic keratitis. Herpetic limbitis is also seen. Another form is the herpetic iridocyclitis, which is the irritative form where you get a direct uveal invasion by virus and they have pain. And again, a herpetic iridocyclitis is the main iridocyclitis which has associated high IOP. Sometimes these patients are wrongly diagnosed as acute angle closure glaucoma and there may be a minimum flare. The commonest presentation is a combined presentation, so evaluate each element fully for appropriate therapeutic modality. Like the patient may present in this manner where he has got epithelial lesion along with the stromal edema. So here first treat the epithelial lesion and then go on to treat the stromal component. This is what I am trying to say is the combined form. This is another way where we get this kind of a dendrite. You see this dendrite and there is associated edema along with that. Interstitial keratitis, you get associated vessel, that is a very severe form. When you get these vessels in the periphery, if you treat it and along with it there is also present an epithelial lesion. So this is a herpetic interstitial keratitis, the treatment being different. Endothelitis, you have a mild stromal edema, few KPs, and there is a loss of central endothelial cell density. Another patient who had a multifocal done came at 3 months with fall in vision. You can see a focal area of edema and there is present a focal area of swelling in the endothelium area. The treatment, once we have diagnosed it's only a dendritic keratitis, fluorescein stain positive, the treatment of choice is 3% ACYCLOVIR 5 times a day. And in the US where the ACYCLOVIR is not FDA approved, you got 1% TFT with supportive treatment. Nowadays 0.15% ganciclovir gel is also available, which may be given 3 to 5 times a day, the effectivity being the same. At 72 hours, evaluate your patient. If there is no or minimal improvement, you must revise the diagnosis because we do not get ACV resistance. You may change the brand of antiviral, check the compliance, see if there is associated dry eye or if there is any associated infection. Also remember that CMV endothelitis is also coming up and at times you may be dealing with that kind of a lesion. I am just trying to show you a typical dendritic keratitis where a dendrite may be in this form, C is stain positive, treated with acyclovir 3% 5 times a day, and at 72 hours you can see that it's absolutely stain negative. In case there is no epi defect and it's only a stromal keratitis, they need a topical diluted steroids which are diluted to full strength depending upon the severity because they minimize the scarring and vascular invasion. Frequent cases of stromal keratitis need oral acyclovir 400 mg BD, maybe 6 to 8 months. Management, if you have a complete epithelial and stromal keratitis both form, you first, if it's stain positive, you give topical antiviral, let the epithelial lesion heal. Once the patient goes stain negative, the topical steroid needs to be added. If there are frequent recurrences, you give oral acyclovir. If there is a graft patient, you may get a viral dendrite in a graft. These are the patients in which oral acyclovir is a must, and you may combine oral acyclovir because this viral keratitis in a graft may trigger a graft rejection and a failure. So you may need to add MMF also in these patients. If you have a non-resolving keratitis, you may think that what time of the frame you are dealing with this particular condition. Not uncommonly, simple dry eye is wrongly diagnosed as viral keratitis and put on acyclovir. Also acyclovir has a drug toxicity of a dry eye. Associated stromal edema, patient using steroids may lead to non-resolving and a superinfection. The indications of using oral acyclovir, which I am very frequently using if you have recurrent stromal keratitis or recurrent epithelial keratitis. If there is a stromal keratitis with a large epi defect, viral keratitis in a graft, poorly responding epithelial keratitis, and if I get a viral keratitis post-cataract glaucoma surgery, put the patient on oral acyclovir. This is one case I am just trying to show. This was one case of a viral keratitis which had healed. You can see there's a catheter along with it. Once I had put the patient on oral acyclovir and it was 6 months healed, I took up the patient for a cataract surgery after that. To my surprise, after putting he's had a cataract, within 3 weeks the patient lands up with a large epi defect. There's a stain positive. So there's a recurrence of viral keratitis post-cataract surgery which responded with the addition of oral acyclovir further. These patients all need long-term follow-up to evaluate any drug toxicity or a steroid-induced glaucoma. The future of viral keratitis lies in treating them with immunomodulators, topical FK506, gene treatment, disc vaccines. I have not dealt about heads because of the short of time, but I've just crystallized that one has to be a little liberal in the use of oral acyclovir. The prevention, now that more of research is going in the prevention of viral keratitis, is in the evaluation of LATs and trigeminal ganglion latency. There are different entities which masquerade as viral keratitis. It may be a necrotizing keratouveitis, severe iridocyclitis, corneal edema, hemorrhagic uveitis, and neurotrophic keratitis. So effectively, I just want to, in a nutshell, want to say that there has to be a good play between topical acyclovir, topical full strength diluted steroids, oral acyclovir and lubricants to lead to treatment of the viral keratitis. Thank you very much.